Hello and welcome to today's presentation on the impact of acute and chronic illness. So as future nurses, understanding this topic is crucial as nearly 20% of children under the age of 17 in the US do have special healthcare needs. A child is designated as having special healthcare needs if they're at risk for a chronic physical, developmental, emotional, or behavioral condition that requires more healthcare than a child who does not have a chronic illness or disability. Behavioral conditions and mental disorders, such as depression, are also co-occurring issues for children who have physical conditions, so it's important to remember that they can happen at the same time. And today we're going to explore how these conditions impact children and families and discuss our role in providing comprehensive nursing care, as well as addressing how children deal with death, both of themselves and of others. So chronic illness is defined as a disease that lasts longer than 12 months, requiring continued medical care or that interferes with daily living activities. So let's look at some important statistics that highlight the prevalence of chronic conditions in children. Currently, 25% of school-aged children have at least one chronic health condition, with about 6% of them managing multiple conditions. In fact, chronic illness surpasses acute illness in terms of children's health concerns. And this is partially due to decreases in mortality. Less children die of infectious diseases because of vaccination and better health care. More premature infants are surviving early birth, right? We can now help babies that are 23 weeks gestation, and many of them grow up to have significant health alterations that need to be managed. There's also medical advancements that have allowed children with severe congenital defects, such as certain heart defects, to survive longer than in the past. So this list here is some of the most frequently encountered chronic conditions in the pediatric population. Asthma leads as the most common condition. We also frequently see diabetes, food allergies, epilepsy, depression, ADHD, and congenital heart disease. Each of these conditions requires unique nursing considerations and management strategies. And it's also important to note that mental health conditions affect 16% of children as well. So a disability, to define it, is a physical or mental condition that creates challenges for the child to perform certain activities and or limits their interaction with their environment. And this can manifest in many different ways, such as vision or hearing loss, communication challenges, or even learning disabilities. And the effect of this disability would depend then on the degree of impairment, the limitation of activity, and restriction of involvement with their environment. So we're not going to focus too much on the conditions specifically as they're weaved into the rest of the content in this course, but rather speak a bit about the impact that it would have on the child and family, and then transition into end-of-life care. So early intervention is a set of services that is provided to children under 3 with disabilities or delays. It consists of services like occupational, physical, or speech therapy. In fact, Emmy, my 11-year-old, had an assessment as an infant due to her prematurity. She was a 29-weeker, and so she qualified for physical therapy services at the time. I think we opted to utilize Carl rather than EI. And in retrospect, I'm not sure what the deciding factor was there, but I do remember that we ended up having a reassessment further down the road when they came to us, and ultimately she did not require services anymore once her gross motor delays caught up around 2 years of age. Once they get into the school environment, our goal is to keep these children in mainstream classes, which is defined also as the least restrictive environment, or LRE. And this helps both the child as well as their peers normalize their conditions and needs, and ultimately is more successful than the separation that we used to see. Individualized education plans, or IEPs, and 504 plans are utilized in this environment to create goals and accommodations to assist these kids during the school day. As you all know by now, family-centered care is the cornerstone of pediatric nursing, and parents are the primary caregivers and must be actively involved in decision-making. I want to correct that because parents are not always the primary caregivers, but they may be. Parenting difficulties such as poor mental health, family conflict, or child behavior problems can lead to poor adherence to care plans and worse outcomes, so it's really important to treat the family as a unit. This leads to collaborative decision making, as both children and parents generally want to be involved. And it's also important to recognize the responsibility and stress that caregivers of children with complex healthcare needs take on. Even leaving home for appointments can require significant pre-planning. Respite care allows short breaks from caregiving duties, but it can be really limited by financial resources or access to social support. And finally, interdisciplinary care coordination can help optimize outcomes as well. Most cities have local resources for caregivers, such as the Division of Specialized Care of Children, or DSCC, here in Champaign. It is still a very underutilized service. In fact, only about 25% of parents that report care coordination are reporting care coordination. So there's still about 75% of families that do not have access to this for one reason or another, but this can provide crucial interconnection between services such as the primary hospital, the school, the insurer, and other community resources. The impact that the child's illness has on caregivers and family depends on several factors, as you can see here. It's dependent on the nature of the illness and how high needs the child may be, what the daily routines are, and how much uncertainty is involved. Is the child always getting sick or requiring medical care? Is their short-term outlook unknown? If the child is severely developmentally delayed, there's going to be more responsibility on the family to assist that child physically and for much longer than if delays are more minimal. We also have to think not only of the primary caregivers, but the siblings in the family who may feel left out or overly responsible or maybe confused by the situation. This can also occur even with milder chronic disorders. Addie, my 8-year-old, has had massive tantrums for years, and over time the effect of that that it has had on our family dynamic has been pretty significant, and the way that Emmy perceives treatment of Addie over her can't be ignored. Emmy has felt like we're harder on her than on Addie, unfortunately, due to the concessions that we sometimes have to make to prevent a behavioral outburst. So it's really important to consider the family as a whole and to treat them as such. So caregiver reactions to chronic illness in a child can vary, as you can imagine. Anything from shock and disbelief to grief over the loss of what they expect their child to be and to experience as parents or caregivers. Some may be in denial or be angry. They might project their guilt. We can see some of this come up during hospitalization as well, right? Even for otherwise healthy children. So it's important to help families find ways that they can share their burdens that are imposed by illness with individuals both inside and outside the family. Support should start at diagnosis and adjust as needed as the situation changes. Education, empowerment, and permission for respite are significant aspects of caregiver support as well. So many children with chronic illnesses do well despite their challenges, but then some unfortunately do not. Some examples of terminal illness in pediatrics include cancer, cystic fibrosis, some metabolic disorders, and congenital heart defects. So this is going to bring us to palliative and hospice care. Palliative care starts at diagnosis, not near death. It aims to provide symptom relief, comfort care, family support, and quality of life improvements. Our goals in palliative care are to relieve distress, provide support, and enhance the quality of life of the child and the family. So nursing care for palliative care is pretty standard here, but your focus would be a bit different in terms of more complex emotional and family supports. You're going to be providing information and acting as the go-between for the family and the healthcare team, provide emotional support, advocate, and also do routine nursing care for the patient. So now this is where people are often confused, palliative versus hospice care. So hospice encompasses palliative care, but it's a program that's often aided by insurance. It's a service. So these are requirements, there are requirements to be placed in hospice that insurance determines, and that's usually that death has to be anticipated within about 6 months. Hospice can be provided at home or at a hospice facility, and it does include palliative care, as this is more of, again, a service rather than an approach. Palliative care is an approach. So palliative care will allow the patient to receive active treatment. I've known many patients to be on palliative care for years. They were not close to death, but required and desired more complex coordination and care. So keep those differences in mind. Now, here's a case scenario that we can go through just to sort of demonstrate. James is a 16-year-old adolescent diagnosed with an inoperable brain tumor. His treatment was not successful for cure, and his care was transferred to hospice. So in this case, what is the role of palliative care within hospice? Is it to provide pain and symptom management, to continue to treat the disease with hope for a cure, to provide respite care for the family, or to support the family through the dying process? It is A, to provide pain and symptom management. Now, at the time of transfer to hospice, the nurse completes a comprehensive patient assessment to determine James's specific care needs. Which of the following components of care should be given the highest priority during terminal stages of illness? Would it be nutrition and hydration, pain management, patient positioning, or skin care? The answer here is going to be pain management. The others are important, but pain management will be our highest priority at end of life. 2 months later, James dies at home. During a follow-up phone call, the nurse determines that the parents are depressed. Identify the best way for nurses to assist parents with some of their feelings of loneliness and emptiness after the death of a child. Should we encourage the parents to keep busy, provide education on the normal feelings of grief, begin to socialize with the parents, or refer the parents to a psychologist? Answer here is B. Okay, A dismisses their feelings, right? Socializing with them is outside scope, and referring them to a psychologist might be appropriate at some point, but initially we want to help them ourselves and not outsource our nursing care. So a child's comprehension in reaction to prolonged illness and dying is very dependent on their developmental level. So we're going to go through each stage and talk a bit about how they perceive death and what their behaviors may look like. Keep in mind that this is in general, so we're discussing not only their own understanding of death, but also the death of others and also the effects of prolonged illness. Okay. So when an infant is sick, this can negatively affect parent and child attachment due to separation because of extended hospitalization or maybe just condition of that child that maybe they can't be handled as much. This can have developmental impacts because they're in that trust versus mistrust phase and they want their needs to be met. There's also sensory limitations. Babies with hyperbilirubinemia need eye shields on for much of the day to protect them from the light. NICU babies are in isolettes, so sometimes there's minimal sound that's transmitting through, or they're not going to be touched or handled as much, so they're not getting that sensory input. Obviously, we can't really ask infants what they think, but based on what we know about development, they don't really have a concept of death for themselves or others. People are here, and then they are not, so very much that object permanence, out of sight, out of mind for this age group. Toddlers will lose autonomy when they are sick. Sometimes they will experience gross and fine motor delays if their hospitalization is prolonged. It can also be really difficult to find daycare and respite care for the chronically ill toddler just due to the specialized care that is required. So this can create a strain on the family when they're trying to manage work and caring for their child at the same time. Developmentally, toddlers are egocentric, remember, so they only perceive things in terms of themselves. So they are alive, so everybody else is alive, unless they are not, and then it's just not. They'll adjust to the absence of a person over time, but they just don't comprehend death. They might regress in behaviors as a reaction to the loss and in an attempt to regain control. And they might perceive the stress around them and recognize the sadness of others, but they can't really understand why. So as caregivers, we would be providing reassurance, physical and otherwise, and then provide comfort items and familiarity. The chronically ill preschooler will not have much opportunity to develop a sense of initiative. Sometimes exposure to other children could be limited, so their social skills can suffer, and these children may have some difficulty developing a sense of body image. Illness can be seen as punitive in this age group. They might have some vague symptoms due to maybe stress of someone else being ill, and they could also regress, but this is more apparent in the younger toddler age. Remember that preschool is magical thinking, okay? So SIDS is a significant type of death for this age group due to this. The child who loses an infant sibling may feel responsible and guilty for that death. Death might be seen as temporary, like sleeping, so it is really important that we use specific language with this age group because they're going to take those meanings literally. So if you say, you put Fido to sleep and now he's gone forever, that child may not want to go to sleep because they're going to think that's going to happen to them. They also might see death as reversible and ask when that person or when they would be coming back. And so in this case, accurate and simple language is important, and any misconceptions that preschooler has should be clarified. Illness in school age will limit peer interactions and can have impacts on their school attendance. These children should be involved in decision making and treatment if able, but just keep in mind that they are still concrete thinkers. So they try to understand death in a way that they can relate to. My 8-year-old is doing that now, and it is so hard. She knows it's final, but she has tons of questions about what comes after and where we go and if we live again. And, she's starting to form these ideas of finality, but she's still, you can see that resistance where she doesn't quite want to believe it yet. There's definitely this fear of not knowing and wanting to have more control over the idea. She's constantly worried about losing her dad and me. She's been mourning the loss of her cat for 2 years now. So there's definitely this battle between, the growing brain and the understanding and the developmental growth there, and still that more preschool, early school age belief that she is struggling to reconcile. These school age kids need the chance to talk and express their feelings. They need to work it out and process it. Outlets are important, so we should let those feelings come and answer their questions honestly, but also provide reassurances. Now, teens can conceptualize and think abstractly, so chronic illness has them thinking about the effects on their future and what this might mean for them. They may experience isolation from their peers, either physically or even maybe socially or emotionally, due to what they have to face during their illness experiences. In regards to death, adolescents are similar to adults. Though they may feel invulnerable, like death is too far in the future for it to happen to them, if faced with death or the death of a loved one, they might feel alone or isolated and have trouble accepting. Additionally, terminal illness in teens can cause physical changes like hair loss or weight loss that can affect their body image and their self esteem. They may also start searching for spiritual meaning or consider what might come after. Teen support groups are great for peer interaction and relationships. We should be allowing as much control as we can and be honest with them. Expression of emotions in this age group can come in many different forms. They could withdraw or lash out or be unpredictable. So it's important just to provide them as much support and control as possible. So, in summary, we should consider the child's cognitive abilities to determine their stressors as well as what coping mechanisms they might have. As you can see, as we looked at their responses to illness and death, it very much overlaps with what we know about development and developmental milestones and stages. The explanations for children who are ill should be given every time. So even if they've experienced something before, is this their 50th IV? I don't care. I'm walking you through it and I'm going to tell you everything like it's your first time. Okay. And as always, consider the family as a single unit and always keep in mind that the overall function and their needs need to be met in order to best provide care. All right. That completes this lecture. Have a great day.